My name's Dr. Jennifer Vidler, and I am a haematology doctor at King's College Hospital, at the moment specialising in myeloid and transplant clinical trials. I'm going to cover some information about clinical trials, just sort of what they are, why someone might be interested in taking part, what the different phases are, and then talk a little bit about trials that we've had open recently in the UK for MDS and CMML, and then a bit about looking forward what there might be coming, particularly in the centre I work in. Now, it's not sort of specific advice for individual patients, but general information about the clinical trials sort of setting in the UK. So I suppose, first of all, what are clinical trials and why do we need them? Well, essentially, a clinical trial is part of the pathway of approval for a new medication. And the aim is to get new treatments available to the patients that need them. And drugs go from becoming an idea of a pathway or a mutation or something to target in a disease, to designing the medication itself, to then testing it in normally animals first, and then in humans, and then in patients with the disease, and then finally working out whether or not it works better than the current medication options. And we call this development pipeline phases of clinical trials. And you'll hear them called phase 1, phase 2, phase 3, and phase 4. And I'll just go through each of these phases to give you a bit of an idea about what taking part in a trial in each of these phases might look like, what it would be like for you as a patient, and why we do them. So if we start with phase 1, this is the beginning of testing something that might become a drug in the future. And the main purpose of the phase 1 trial is to ask, is this safe in humans? So often, phase 1 studies are undertaken in healthy volunteers. However, in cancers, usually, actually, these are patients who have the condition. And they're small numbers, maybe up to 20 people, could be less, might be more, but very rarely more than 50 volunteers. Often these trials have an inpatient stay at the very beginning so that patients can be monitored really closely to see whether or not they have any reactions. But this depends on the type of medication or treatment that's being tested. It's common to take lots of blood tests during this time so that we can see how the drug is metabolized, so how your body deals with the drug. So often there'll be a blood test before the drug is taken, and then some hours afterwards, maybe every 2 hours for up to 6 or 8 hours. And that's to work out how our bodies process the medication. This can be what we call blinded or unblinded. So you might know what the drug is. More often than not, they're unblinded. So you know that you're getting the medication. And often the doses start small and then they increase as more people get the lower dose, and it's proven to be safe. Often there's sort of a 3+3 kind of design where you give it to 3 patients at a lower dose and then move up to the next dose if that original dose is found to be safe. And what we're measuring in a phase 1 trial is this safe? Is this potential medication safe? It's not about does it work, it's about is it safe? So I think if you're thinking about taking part in a phase 1 trial, then you need to be aware that the outcome of this trial is about safety and not about efficacy. Does it work? And we want to know, is it tolerated? What are the kind of side effects that people get? And then if the trial looks positive, if it's tolerated well in patients, then it can move on to a phase 2 trial. So a phase 2 trial is asking the question, does this drug work in people that have the disease? And normally there's more people involved in this trial. So we're up to about 300 people in a phase 2 trial, although this depends on how common the disease is. In rare diseases, you're unlikely to be able to get those kind of numbers in a phase 2 trial. Sometimes these trials have a placebo, and a placebo is a medication that looks exactly like the actual active medication, but doesn't have any active ingredients in it. So it might be a sugar pill, or it might be a bag of saline water instead of an IV medication or an injection, but it will look exactly the same. And it could be randomized, and a randomized trial means that you're selected to either have that placebo or the active medication randomly. Often it's computer generated. And the question that the phase 2 trial is asking is, does this medication work? And again, is it safe? Does it work in the people who have the disease? And does it achieve what we want it to achieve? And again, if we're achieving what we want to achieve in the phase 2 study, then we'll move on to the next phase, and that is phase 3. So the aim of a phase 3 trial is to give the new medication to lots more people, often up to thousands of people, depending on the kind of medication. If it's in a rare disease, you're not going to find 3,000 people to take part. If it's a vaccine, you might need to give it to 20,000 people. Often phase 3 trials are across many hospitals and international centres most of the time. And the aim of the phase 3 trial is to prove whether or not the treatment works better than whatever is the current treatment. And the gold standard phase 3 trial will be a randomized, so you're randomly assigned to get the drug or a placebo, and placebo controlled. And blinded, meaning no one knows what you're getting. The patient doesn't know whether they're getting the medication or the placebo. The doctors don't know, the pharmacists don't know. And that's important because we need to remove bias. We need to remove the assumption that the new drug works or doesn't work. And phase 3 studies are what's required usually to get a drug licensed. And like I said at the beginning, this is the aim, to try and get new drugs available to patients, particularly in hard to treat diseases like MDS. And the outcomes of a phase 3 trial is asking the question, does this help? Does it help? And not just that, is it better than what we can offer already, or at least not as bad? So studies can be designed to be equally as good as whatever is currently available or better than. You need more people and a better design study to prove that your drug is better than the current treatment. And it's really important that we get good, high quality data for phase 3 studies, because that's going to be put forward to the regulators. And the regulators in the UK is the MHRA, and there's the EMA in Europe and the FDA in the US. And that's what leads to a drug getting a license and being able to be prescribed for that condition. And these regulators decide whether or not the drug can be sold. It doesn't necessarily mean that there's access to the drug. So this is a study that was running in patients with CMML. And just to give you an idea of a clinical trial scheme and also what that would mean if you were a patient, at the beginning, if you decide that you would be interested in taking part in a trial, then there'd be an initial screening period. The trial team would have a look to see if we think you might be eligible. So for example, we're running a study in low-risk patients with MDS who need transfusions. So do you meet that criteria? And there'll be other criteria, like you might need adequate heart function or kidney function. So we have a look and we think, oh, you look like you might be suitable for this. And then we would offer that trial to the patient. We'd give them an information sheet to go away and have a look at and read, and that's provided by the trial. And then after you've had some time to have a think about it and want to join the trial, you'll come and see a doctor who'll go through all of the different points about the trial, what the expected side effects might be, what the evidence is that this drug might be useful in your condition, what happened to people in the earlier phase trials, say if it's a phase 3 trial, what happened in the phase 1 and the phase 2. And then if you're happy to go ahead, you would sign a consent form, knowing that you can withdraw at any time and for any reason, and it won't affect your treatment going forward, and that it's completely voluntary. And then there'll be a screening period, and usually this involves some tests. Often, unfortunately, in MDS or AML, it involves a bone marrow biopsy and blood tests, maybe tests of your heart or your kidneys, depending on what the drug is. And then at the end of that screening period, the sponsor, the person that is running the trial, which could be a company or it could be a university, they decide whether or not they think you're suitable for the study, and then you enter the study and can be randomized if it's a randomized study. So I think during that period, if you were to think about entering a trial, we can think later about some of the questions you might ask, but part of it is understanding what the medication is, how likely you are to get a placebo, what the side effects of the drug seem to be, and how that compares to what you would get anyway. And then if you're randomized, for example, in this trial, it was randomized 2-to-1 to the drug. So out of 3 people, 2 of them would get the study drug and 1 would get the standard treatment. And then you'd continue taking either your standard treatment or the study drug. And in this trial, after 6 months of the standard treatment, that would be it. And you would be followed up. And if you were on the study drug, we'd ask the question, have you had a benefit? Have you had a clinical benefit after 6 months? And do you want to continue? And if you would like to continue, then you can continue on the drug. And if you don't want to continue, then that's fine, you finish. And then there's annual follow-up, which is usually a phone call or sometimes coming into the hospital to be checked out at the end of a year. Now, another thing to note is on this study, there was a question about what would happen at the end of the trial. So the company are providing the drug for the duration of the study, but what happens when the study finishes? And that's a question to think about if you're going to enter a clinical trial. So the plan had been that everyone would have to stop at the end of the duration of the trial. But what if you were getting clinical benefit and you had to stop? How would you feel about that? Now, this is a bit of a busy slide, but I just want you to have a look at the top line here. This is a summary of how trials progress from early phase studies into getting an approval rate. And you can see that haematology is right at the top there with lots of green, essentially saying that studies that start off in phase 1 have a greater chance of becoming a drug that gets approved in the end compared to any other specialty, really, even including big ones like oncology and cardiovascular disease. So the first column is if you're going from a phase 1 to a phase 2, how likely are you to progress? And so it's quite high in all of the areas. And if you pass a phase 3, a drug is 93% likely to become a licensed drug at the end of it. So taking part in a clinical trial in hematology really is quite likely to end up in a drug that we can use to treat patients in the future compared to other specialties. However, that doesn't necessarily mean we all have access in the UK. So a drug might be successful in getting a license, but that doesn't mean it's available to patients on the NHS. And that's where the National Institute for Health and Care Excellence, NICE, comes in. NICE appraise all new potential medications and decide whether or not it's essentially cost effective for the NHS to provide them. And so we've seen that with a drug called luspatercept in MDS, where we've run the trials here in the UK, and the drug has a license by the MHRA, so it can be prescribed, but it's not reimbursed by the NHS, so it's not available to everyone. That is an example that you might have heard of. So when we've completed our phase 3 study and we have a drug which has gained a license, we can then move on to phase 4. And this is sometimes called sort of post-marketing surveillance. And it starts after the medicine is approved. And this is to look at what it's like in the general population of patients that are taking the medication that outside of the clinical trial, because we select a careful group of patients to enter the trial. And that's not necessarily reflective of people that will get the drug in the longer term. And there may be rarer side effects that we won't have captured in the earlier trials. For example, if the side effect only occurs in one in every 5,000 patients, but you've not had 5,000 patients in the trial, then you might not have captured that rare side effect. It also allows us to have a look into different subsets of people. So how does this drug act in people of different ages or different ethnicities? Or what if we use it in a slightly different indication to the one that the trial was designed in? So it helps us maybe expand the use of the medications. It also helps us to think about interactions between other drugs, look at new doses, or compare with other products. And sometimes these studies can lead to new warnings if something serious is identified, or possibly different uses of the medication in the future. So it's important that we keep looking at new medications and analysing them after they have been licensed. And this is an area that's sort of in development at the moment. People are quite interested in phase 4 studies. So now if we think about what the potential positives are of taking part in a clinical trial, well, I think the main one needs to be that you need to acknowledge that this will be for contributing to future knowledge, but it might not necessarily have a direct benefit for you, particularly with early phase clinical studies. However, it might allow you to access potential new medications where there might not be other medication options for you at present. We know that people in clinical trials in general do better than people not in clinical trials, probably because they have more close monitoring, even if you don't access the drug. And you often have high quality care in big centres with lots of specialists looking after you. Early phase clinical trials in particular can offer treatment options where all standard options have failed or there are no future standard options available. It can offer hope to patients where there are no further treatments. And also it can be quite empowering to feel like you're taking control of your disease and helping to drive research forward in this area. There are obviously downsides to taking part in a trial as well. Mostly, I would say, is the time commitment. You need to be aware that you will be followed up more closely than you would be usually, often. And this means time away from home, potentially in hospital, definitely in hospitals waiting for appointments, but sometimes there's inpatient stays depending on the medication. You need to travel. It might be traveling to a hospital that's further away from your local hospital because often these trials are just run in big centres and not available locally. And cost. You need to have a think about the cost of travel or staying near the hospital. Now, if it's a commercial study, a study which is funded by the pharmaceutical company developing the drug, then your costs should be reimbursed, and that's a good question to ask. If you're considering a clinical trial. If it's an academic study, then often there's not as much reimbursement for those things. As I mentioned before, there may be more invasive procedures, for example, bone marrow biopsies. Often if we're trialing a new treatment, we want to know how it works both in the blood and in the bone marrow, and that might mean repeated sampling over and above what we would do normally. For example, a bone marrow every 6 months, whereas usually we would only do it if the clinical picture changed. More monitoring, some people find that helpful. Other people might find that too much or not want to think about their condition all the time. Whereas if you're having to have bloods every 2 weeks or every month, then that's always in the forefront of your mind. Some people don't like the idea of a placebo. And so maybe an earlier phase trial might be worth thinking about for those people if they did want to take part in a trial. But if you're in a late phase trial, you need to be comfortable with the idea that you're giving your time and your samples, but you may be receiving a placebo. Some studies will allow crossover at the end of the study. So if you're on the placebo, they'll allow you to access the drug. And so those studies are quite nicely designed because you know that at some point you'll definitely get the medication. And there's often a lag time between a drug, say, working and getting a license. So if the phase 3 is positive and it looks like it works, then it takes some time for the license to come. So you might be able to access that drug earlier by the fact that you've been in the clinical trial. There's also the risk of unexpected side effects or potential harm from taking new medications, and the uncertainty as to whether it works, as to whether or not you're going to continue on the trial or not continue on the trial, get a slot on the trial, not get a slot, whether you're taking the medication or not. So these are all things to bear in mind. But if you were considering taking part in a clinical trial, what do I think you should ask your doctors or your treatment, your treating team? Well, I think you should ask what your standard treatment options are. So if you're not going on the trial, what are your options? Are there any other options? It might be that there aren't any other options and a trial is the only option, or it might be that there's a standard of care that you can access anyway. And then ask how this treatment is different. Is it very similar to the drug that you are being offered? Is it completely different? What's the rationale behind it? Why does your team think that this would work for you? Why might it work in your condition? Some of the earlier phase studies might just take people with hematological diseases. So it might not be specific to MDS or CMML. It might just be for people with hematological cancers. So why do we think it would work in your condition? What's the control arm? Is the control arm something that your doctors would offer you to begin with? it's no good being in a trial where the control arm is worse than you would get as a standard of care. What procedures do you need and how frequently? How many of these marrows are required? How many are optional? How does that compare to how many bone marrows I'd have anyway? Will my costs be reimbursed? Will I be out of pocket? Is this a new medication or is this just using an old medication in a new way? What's known about the trial drug? What happened in the earlier phase studies? What kind of side effects could I expect? And how do those side effects compare to the side effects of the standard of care treatment that might be offered? And are there other trials available? Is this my only trial option? Are there other places in the country that have other trials either coming or open at the moment? And then a really important part that's coming more and more part of how we design trials and run trials is what we call PPI, patient and public involvement. And this is making sure that research isn't done to the public, but is done with or by the public. And the people who have the conditions need to be involved in not just the how the trial is run, but also how the trial is designed. And that makes the research more relevant to the patients, allows us to ask the right questions and design trials that answer the questions that patients want. And so the public can help to decide which topics we research. They can help review patient information leaflets or the protocol itself, and then they can sit on the trial panels. So looking as the trial progresses, there'll be meetings maybe every 6 months or so to check how the trial is doing, see if there are any particular side effects we need to be aware of. And we like to have patients sitting on those panels so that they can have their input into the trial design and the running of it as well. A really good example of this is a study we're running in AML called PROPEL, which is a national study where we asked patients in the UK what they wanted us to study about AML. If we could design a new national study, what would it be about? And we assumed that the answer would be we want new drugs for better cures, but actually the answer was fatigue. Fatigue is really debilitating in AML, and we would like something that made us less tired. And so a study has been designed where the primary outcome that we're looking at is a reduction in fatigue, and it randomizes people between an intensive arm of physiotherapy and input by dietitians and psychological support and compares it to the support they'd get offered anyway. So physio if you need it, and dietitian if you need it, rather than a sort of personalised prehabilitation plan. And that was a trial that was designed because of patient and public involvement. So it's really important. We take it very seriously. Companies take it very seriously. And if anyone's interested in being involved as a patient and public representative, then do get in touch. There's lots of opportunities. So I'm going to move on now to have a think about current and recent UK trials and just speak a little bit about what we've had available for the different disease areas that we're thinking about. So this is low risk MDS. And there are a few studies, and you don't need to know all of the ins and outs of these, but just to show you that there's a title on the left-hand column and then the phase. So we've got a few phase 3 studies and a few phase 2 studies. And also you can see this A and B business. I mean, to be honest, there's recently been lots of blurring of the lines of what is randomized and not randomized and blind and not blinded. But the general principles of phase 1, 2, and 3 still stand. So there's a trial that's open at the moment at King's, which is studying elritercept, which is a bit like luspatercept, an injection under the skin for transfusion-dependent patients with MDS versus placebo. And there's another study of a tablet, which is a phase 2 study that is for a similar group of patients with transfusion-dependent MDS. But that one is not blinded because it's a phase 2. So you can see we have both of these studies open at where I work, and we offer both to patients, and it sort of depends on their risk profile, what patients are willing to accept. So some would like the phase 2 study because they know that they're getting the medication. There's no placebo, you're definitely getting the medication, you know what dose you're getting, but it's an earlier phase study. So it's only been proven to be safe in phase 1, we don't know that it works, because this phase 2 is asking the question, does it work in patients with the disease? Whereas the phase 3 study, the drug is very similar to a drug with a license. It's very similar to luspatercept. And it's also already passed phase 1 and phase 2, so it's much more likely, we know from our previous that previous table, that the study is more likely to get approval as we go along in the different phases. So depending on patients' feelings on a placebo-controlled trial or an earlier phase study, we offer them the one that is the best fit for them. And then there was a study called Repair MDS, which has stopped now, but that was comparing not new medications, but medications we already know about that look like they might have some efficacy in MDS, to see if we could repurpose those medications for MDS to see if patients could get some benefit. And then there's a phase at the bottom of the phase 3B, which really is a phase 4, is a long-term safety study for luspatercept. So the patients that took part in the earlier phase luspatercept studies are followed up longer term to look for any new drug interactions or side effects. So that's a good example in MDS, low-risk MDS here, of all the different phases of studies. If we move on to high-risk MDS, there's some earlier phase studies available here. You can see there's more phase 1, phase 2 studies, and a couple of phase 3s. And a lot of these are thinking about targeting specific mutations in people's MDS and trying to see if we can change the course of the disease. So there's some looking at IDH1 inhibitors for people that have IDH1 mutations. There are some novel treatments like the one that says CCS 1477 inabrodib. That's a new class of drug, and a study that's has been open at the Marsden Imperial UCL, I think, in Manchester. And then there are some immunotherapies as well down the bottom there. So a variety of different studies open. High-risk MDS has been a traditionally challenging area to get new drugs licensed recently. So it's definitely an area of unmet need. And then if we have a look at CMML, well, the AMO study is a big national UK study, phase 2 study of a tablet chemotherapy versus the standard of care, which is hydroxycarbamide or no treatment. That's close to recruitment now, but we have patients in follow-up. And that's the study where I showed you the flow chart earlier on, where we weren't sure whether or not patients could continue the drug at the end of the study. And so that was quite difficult for our patients who'd had a response, because they didn't know whether or not they could continue, and they'd done really well on this medication. But I'm pleased to say the company's now agreed to continue funding it for patients that are on the trial and responding. So that was some good news. And then the other 2 studies are some earlier phase trials that are open for CMML. But again, some of those are more sort of umbrella studies, having more patients with different hematological conditions, rather than it being sort of specific to just CMML or MDS MPN. It's just that those patients are also included in the study, as well as people with high-risk MDS and AML. And a small section about upcoming trials. There's a phase 3 of lisaftriclax and azacitidine in high-risk MDS. That is a bit like venetoclax in combination with azacitidine. That's in high-risk MDS. And then we have an early phase study opening, a phase 1, which is in hematological neoplasm. So that would include an awful lot of people with AML, MDS, and potentially CMML. And then we have a specific trial for CMML coming later in the year, or possibly early next year, which is a tablet versus hydroxycarbamide. There's a trial coming for Vexer syndrome, which is a very rare, unusual condition where patients also have MDS. And then later in the year, we'll have a trial of oral azacitidine, which is for anyone that's had azacitidine, we're very excited about these trials, because it's very tricky for our patients to be coming into hospital for injections every 7 days. And if we could give that as a tablet at home, we think that would really improve quality of life.